Hello, Audio Medical Basics, Brick Face, Case Files Books, Internal Medicine, case number 3 of the cycle. And today we'll be reading a case about pancreatitis, gallstones. Pancreatitis caused by gallstones. And we'll make a small change here. First is we'll be reading the long case first before the summary. And we also will be do something different, which is, inshallah, I'll be reading the whole case in one video instead of spreading it into 3 videos, and see how that goes. And you haven't answered me yet about the MCQs at the end of the case, so please let me know if you want me to read these. They're important, but they're gonna take time. If you don't like them, don't let me read them. Okay, so let's go on with the case. So the long case. A 42-year-old woman presents to the emergency department complaining of 24 hours of severe, steady epigastric abdominal pain, radiating to her back with several episodes of nausea and vomiting. She has experienced similar painful episodes in the past, usually in the evening following heavy meals, but the episodes always resolved spontaneously within an hour or two. This time, the pain did not improve, so she sought medical attention. She has no medical history and takes no medications. She is married, has 3 children, and does not drink alcohol or smoke cigarettes. On examination, she is afebrile, tachycardic, with a heart rate of 104 beats per minute, blood pressure 115/74 millimeter mercury, and shallow respirations of 22 breaths per minute. She is moving uncomfortably on the stretcher. Her skin is warm and diaphoretic, and she has scleral icterus. Her abdomen is soft, mildly distended, with marked right upper quadrant and epigastric tenderness to palpation, hypoactive bowel sounds, and no masses or organomegaly appreciated. Her stool is negative for occult blood. Laboratory studies are significant for a total bilirubin 9.2 gram per deciliter with a direct fraction of 4.8 gram per deciliter. Alkaline phosphatase 285 international unit per liter, AST 78 international units per liter, and ALT 92 international units per liter. And elevated amylase level 1249 international units. Her leukocyte count is 16,500 per cubic milliliter, with 82% polymorphonuclear cells and 16% lymphocytes. A plain film of the abdomen shows a non-specific gas pattern and no pneumoperitoneum. So, the questions of the case: what is the most likely diagnosis? What is the most likely underlying etiology? What is your next diagnostic step? I give you 1-page turn to answer the questions. Okay, so now, summary of the case. A 42-year-old woman with a prior history consistent with symptomatic cholelithiasis now presents with epigastric pain and nausea for 24 hours, much longer than would be expected with uncomplicated biliary colic. Her symptoms are consistent with acute pancreatitis. She also has hyperbilirubinemia and an elevated alkaline phosphatase level, suggesting obstruction of the common bile duct caused by a gallstone, which is the likely cause of her pancreatitis. So, to answer the questions, what is the most likely diagnosis? which is acute pancreatitis. The most likely etiology is cholelithiasis, which is common bile duct stone. Next diagnostic step is right upper quadrant abdominal ultrasonography. So, I will not read the analysis and objectives of the case. I'll just go directly to the consideration this time. This 42-year-old woman complained of episodes of mild right upper quadrant abdominal pain with heavy meals in the past. These prior episodes were short-lived. This is very consistent with biliary colic. However, this episode is different in severity and location of pain, which is now radiating straight to her back and accompanied by nausea and vomiting. The elevated amylase level confirms the clinical impression of acute pancreatitis. She likely has acute pancreatitis caused by a stone in the common bile duct. Biliary obstruction is suggested by the elevated bilirubin level. She is moderately ill, but is hemodynamically stable and has only one prognostic feature to predict mortality, which is her elevated white blood cell count. Later on, we'll be mentioning why we spoke about this prognostic feature, which is a part of the Ransom criteria for severity of pancreatitis. We'll get to this later. She likely can be managed on a hospital ward without the need of intensive care. Definitions. Acute pancreatitis is an inflammatory process in which pancreatic enzymes are activated and cause autodigestion of the gland. Pancreatic pseudocyst is a cystic space within the pancreas not lined by epithelial cells, often associated with chronic pancreatitis. Clinical approach. Acute pancreatitis can be caused by many processes. The most common cause is biliary tract disease, usually due to passage of gallstones into the common bile duct. Hypertriglyceridemia is another common cause and occurs when serum triglyceride levels are more than 1000 mg per deciliter, as is seen in patients with familial dyslipidemias or diabetes, as we'll go to the table of etiologies later on. When patients appear to have idiopathic pancreatitis, that is, no gallstones are seen on ultrasonography and no other predisposing factor can be found, biliary tract disease is still the most likely cause by either a biliary sludge, which is microlithiasis, or sphincter of OD dysfunction. So now we'll read a table for the causes of acute pancreatitis. Causes of acute pancreatitis: biliary tract disease, for example, gallstones, alcohol use, drugs such as the antiretroviral didanosine, pentamidine, thiazides, furosemide, sulfonamides, azathioprine, L-asparaginase. Also, other causes of acute pancreatitis: surgical manipulation of the gland or ERCP, hypertriglyceridemia / hypercalcemia, infections such as mumps or cytomegalovirus, trauma such as blunt abdominal trauma. We finished reading the table. Abdominal pain is the cardinal symptom of pancreatitis and often is severe, typically in the upper abdomen with radiation to the back. The pain often is relieved by sitting up and bending forward and is exacerbated by food. Patients commonly experience nausea and vomiting that is precipitated by oral intake. They may have low-grade fever and often are volume depleted because of the vomiting, inability to tolerate oral intake, and because The inflammatory process may cause third spacing with sequestration of large volumes of fluid in the peritoneal cavity. The most common test used to diagnose pancreatitis is elevated serum amylase level. It is released from the inflamed pancreas within hours of the attack and remains elevated for 3 to 4 days. Amylase undergoes renal clearance, and after serum levels decline, its level remains elevated in the urine. Amylase is not specific to the pancreas, however, and can be elevated as a consequence of many other abdominal processes, such as gastrointestinal ischemia with infarction or perforation. Even just the vomiting associated with pancreatitis can cause elevated amylase of salivary origin. Elevated serum lipase level, also seen in acute pancreatitis, is more specific than is amylase to pancreatic origin and remains elevated longer than does amylase. When the diagnosis is uncertain or when complications of pancreatitis are suspected, CT imaging of the abdomen is highly sensitive for showing the inflammatory changes in patients with moderate to severe pancreatitis. Treatment of pancreatitis is mainly supportive and includes pancreatic rest, which is withholding food or liquids by mouth until symptoms subside, and adequate narcotic analgesia, usually with meperidine, which is Demerol, I think. Intravenous fluids are necessary for maintenance and to replace any deficits. In patients with severe pancreatitis who sequester large volumes of fluid in their abdomen as pancreatic ascites, sometimes prodigious amounts of parenteral fluid replacement are necessary to maintain intravascular volume. Patients with adynamic ileus and abdominal distension or protracted vomiting may benefit from nasogastric suction. When pain has largely subsided and the patient has bowel sounds, oral clear liquids can be started and the diet advanced as tolerated. The large majority of patients with acute pancreatitis will recover spontaneously and have a relatively uncomplicated course. Several criteria have been developed in an attempt to identify the 15% to 25% of patients who will have a more complicated course. These include the Ransom and Glasgow Emery criteria, as well as Apache 2 scoring system. When 3 or more of the following criteria are present, a severe course complicated by pancreatic necrosis can be predicted by Ransom criteria. So we'll read to you the Ransom criteria from the table here, and I went online and found that there is two. There is Ransom criteria and there is the modified Ransom criteria. The Ransom criteria is for the alcoholic pancreatitis, and the modified Ransom criteria is for the Gallstone pancreatitis. So I'll read both here. First, I will read the Ransom criteria for the alcoholic. Then I will read the modified Ransom for the Gallstone pancreatitis. So first, Ransom criteria. Initial, age more than 55 years, WBC more than 16,000 per cubic millimeter, white blood cells, serum glucose more than 200, serum lactate dehydrogenase, LDH, more than 350 international units per liter, AST more than 250 international units per liter. So these are the initials, then the initial 5, then the other 6 of the criteria within 48 hours of admission. The other 5. Hematocrit drop more than 10 points. Blood urea nitrogen BUN rises more than 5 milligram per deciliter after intravenous hydration. Arterial PO2, arterial oxygen less than 60 millimeter mercury. Serum calcium less than 8. Base deficit more than 4. Base deficit more than 4 milliequivalent per liter. And estimated fluid sequestration of more than 6 liters. So this was the Ransom criteria, which was for alcoholic pancreatitis. Now for the modified Ransom criteria for the Gallstone pancreatitis. So the initial five, age more than 77 years old, WBC, white blood cells, more than 18,000 per cubic millimeter, serum glucose more than 220, serum lactate dehydrogenase, LDH, more than 400 international units per liter, and AST more than 250 international units per liter, which is the same as the Ransom criteria. So these were initial 5. The other 6, which are within 48 hours of admission, hematocrit drop more than 10 points, same as Ransom. Blood urea nitrogen BUN 2 or more milligram per deciliter after intravenous hydration. Arterial PO2 is not in the modified criteria. It's only in the Ransom criteria for alcoholics.
It's only for the Ransom. The modified has no arterial PO2.
Serum calcium less than 8 milligram per deciliter. Base deficit more than 5 milliequivalent per liter, and estimated fluid sequestration of more than 4 liters. So that was the modified Ransom criteria. So that was about the table for Ransom criteria. The most common cause of early death in patients with pancreatitis is hypovolemic shock, which is multifactorial. Third spacing and sequestration of large fluid volumes in the abdomen, as well as increased capillary permeability. Others develop pulmonary edema, which may be non-cardiogenic as a consequence of acute respiratory distress syndrome, or cardiogenic as a consequence of myocardial dysfunction. Pancreatic complications include phlegmon. Pancreatic complications include a phlegmon. A phlegmon is a solid mass of inflamed pancreas, often with patchy areas of necrosis. Sometimes extensive phlegmon can become secondarily infected, resulting in pancreatic abscess. Abscesses typically develop 2 to 3 weeks after the onset of illness and should be suspected if there is fever or leukocytosis. If pancreatic abscesses are not drained, mortality approaches 100%. Pancreatic necrosis and abscess are the leading causes of death in patients after the first week of illness. A pancreatic pseudocyst is a cystic collection of inflammatory fluid and pancreatic secretions, which, unlike true cysts, do not have an epithelial lining. Most pancreatic pseudocysts resolve spontaneously within 6 weeks, especially if they are smaller than 6 centimeters. However, if they are causing pain, are large or expanding, or become infected, they usually require drainage. Any of these local complications of pancreatitis should be suspected if persistent pain, fever, abdominal mass, or persistent hyperamylasemia occurs. So now we'll talk about gallstones. Gallstones usually form as a consequence of precipitation of cholesterol microcrystals in bile. They are very common, occurring in 10% to 20% of patients older than 65 years. Patients often are asymptomatic when discovered incidentally They can be followed without intervention, as only 10% of patients will develop any symptoms related to their stones within 10 years. When patients do develop symptoms because of a stone in the cystic duct or Hartmann pouch, the typical attack of biliary colic usually has a sudden onset, often precipitated by a large or fatty meal with severe steady pain in the right upper quadrant or epigastrium, lasting between 1 and 4 hours. They may have mild elevations of the alkaline phosphatase level and slight hyperbilirubinemia, but elevations of the bilirubin level over 3 grams per deciliter suggest a common duct stone. The first diagnostic test in a patient with suspected gallstones usually is an ultrasonogram. The test is non-invasive and very sensitive for detecting stones in the gallbladder as well as intrahepatic or extrahepatic biliary duct dilation. One of the most common complications of gallstones is acute cholecystitis, which occurs when a stone becomes impacted in the cystic duct. And edema and inflammation develop behind the obstruction. This is apparent ultrasonographically as gallbladder wall thickening and pericholecystic fluid, and is characterized clinically as a persistent right upper quadrant abdominal pain with fever and leukocytosis. Cultures of bile in the gallbladder often yield enteric flora such as Escherichia coli and Klebsiella. If the diagnosis is in question, nuclear scintigraphy with the hepatobiliary aminodiacetic acid HIDA scan may be performed. The positive HIDA scan, shows visualization of the liver by the isotope, but non-visualization of the gallbladder may indicate an obstructed cystic duct. Treatment of acute cholecystitis usually involves making the patient NPO, intravenous fluids and antibiotics, and early cholecystectomy within 48 to 72 hours. Another complication of gallstones is cholangitis, which occurs cholangitis, which occurs when there is intermittent obstruction of the common bile duct, allowing reflux of bacteria up the biliary tree, followed by development of purulent infection behind the obstruction. If the patient is septic, the condition requires urgent decompression of the biliary tree, either surgically or by endoscopic retrograde cholangiography, ERCP. Endoscopic retrograde cholangiography, ERCP, to remove the stones endoscopically after performing papillotomy, which allows the other stones to escape, to pass. Clinical pearls, finally. Let's check the shading. Here. Clinical pearls of this case. Please tell me about the comprehensive questions. You want MCQ or not? Clinical pearls. The most common causes of acute pancreatitis in the United States are alcohol consumption, gallstones, and hypertriglyceridemia. Acute pancreatitis usually is managed with pancreatic rest, intravenous hydration, and analgesia, often with narcotics. Patients with pancreatitis who have 0 to 2 of the RANSON criteria are expected to have a mild course. Those with 3 or more criteria can have significant mortality. So those with 3 or more criteria can have significant mortality. Pancreatic complications. Pancreatic complications. Phlegmon, necrosis, abscess, pseudocyst. These pancreatic complications should be suspected if persistent pain, fever, abdominal mass, or persistent hyperamylasemia occurs. Patient with asymptomatic gallstones do not require treatment. They can be observed and treated if symptoms develop. Cholecystectomy is performed for patients with symptoms of biliary colic or for those with complications. Acute cholecystitis is best treated with antibiotics and then cholecystectomy, generally within 48 to 72 hours. Thank you very much for listening. Thank you very much for watching. Please like, share, and subscribe, and leave a comment. Please leave a comment. Tell me anything about the previous 41 videos. Just like give me an idea. This is a toilet paper, by the way. Just give me an idea of what you think. Next case, inshallah, will be a case of emergency from the emergency medicine case files book. Unless one of you, just go comment and like tell me, just get to the comments and say something useful for me. Thank you very much for listening for the مرة الألف و 42 دقيقة for editing. اليوم سبت ويصير خير إن شاء الله. Please take care, have fun, be cool, and be happy, and watch my Be Happy video.